when we serve those in need, we serve Jesus Christ, and mysteriously, Christ serves us. So all our encounters manifest Jesus Christ. And here we're going to speak about individuals with communication disabilities, people who can't speak the way that we with mouths speak with each other all the time. And those people are numbered among the least of our brethren. And as chaplains and pastors, we encounter these people all the time. Maybe not all the time, but we often see them maybe in wheelchairs, people with cerebral palsy, people that have, maybe been in car accidents or suffering from other kinds of disabilities. And especially as doctors and nurses and technicians in hospitals, we may run into those individuals. But also in hospitals, we often have, if you're a doctor or a nurse or a caretaker, you're on a pretty rigid schedule. And you're following, your own protocol and don't always have time to sit and have lengthy conversations with people that might be having communication disabilities. But as chaplains and pastors and visiting hospitals, we often have a little more time to do so. And so this is a presentation that is going to familiarize us a little more with the issues, with people that do have communication disabilities, and maybe what we as chaplains and pastors could do to help them speak. So Dr. Katya Hill is a speech-language pathologist. She's a professor at the University of Pittsburgh. She also runs a nonprofit clinic in Pittsburgh that serves these people. And Father Daniel Mathewson here is a parish priest at St. Peter and Paul's Orthodox Church in Crossingville, Pennsylvania. Dr. Hill is a parishioner of Father Dan's church. And they have individuals in their parish that have communication disabilities, autism, for example. And so they've been working together over the last few years in meeting the needs of these individuals. So, Dr. Hill, thank you.
I'm going to give you some examples. So my part of this workshop is not to do a course in augmentative and alternative communication, which is the field that I work in. And it's a very orphan field because although speech pathology is a large field, not very many speech pathologists have been trained in providing AAC services. And even at a university level, there are still universities that don't offer courses in what my area of expertise is in. So I'm going to introduce you because to this field and give you some ideas of what is possible. Right. This individual is Jen. Jen is on the board of my nonprofit organization, the AAC Institute, and my clinic is I Can Talk Clinic in Pittsburgh. Jen and I have become good friends over the years. She did not have technology to talk until she was 17. So if we talk about perceptions of individuals maybe being non-compliant or resistant to their services, imagine that people would be trying to do something to you or for you, and you could not speak to let them know how you felt about what they were requesting you to do. What would be the way that you would communicate to them? Maybe with behaviors that would not necessarily be pleasant. Okay. So for most of Jen's childhood, her life was playing 20 questions and frequently being so bored or unsettled about what was being requested of her that she just didn't comply or she resisted. The Only God Could Hear Me is a documentary that was done in Pittsburgh, and the title of this documentary came from Jen herself because one of the things she shared to the person doing the filming was that before she had a way to express herself And people were talking to her and maybe asking her many questions that, upon a question, because they couldn't wait for her to even try to respond, she would pray to God that God would take what was in her head and put it in the other person's head so they would understand that she understood. Okay. Jen now has a bachelor's degree. She works for a state educational organization, and as I said, she's on my board. So it's highly likely that you would have a family member, a neighbor, for sure a parishioner, that fits into the category of someone whose natural speech is not functional to meet their daily communication needs. So there's over 4 million people in this country that fit that category. If you're working in a hospital, a recent study at the University of Pittsburgh found that 50% of individuals in the hospital that were mechanically vented could benefit from AAC. Now imagine that spread across the country. And we have an aging population. So disability increases with age, and that increases the possibility of individuals benefiting from clinical services that require AAC. So it's across the lifespan, it's lifelong disabilities, it's acquired disabilities, and then it's temporary disabilities that you might be in a hospital situation where whatever was your medical condition, you are temporarily having a need for AAC. This gentleman has Parkinson's, but then he had a stroke. And he went from a hospital to a rehab facility and then a SNF, covered by Medicare. So you would have 100 days in that skilled nursing facility. Now, the speech-language pathologist in the SNF was doing swallowing and feeding interventions with him, but he was not provided with any alternative means to communicate, although he was speechless. What happened is his wife went out because she believed that he was still intact in his mind. It was just that his speech wasn't working. You can see the ABC puzzle. She went to a toy store, found that ABC puzzle, and had him using that to be spelling out basic communication with her. It was then that the family called my clinic in, and I went in to work with this gentleman. I found very shortly that indeed, language-wise, he was intact. And he could benefit from technology that would be voice output. So I did an evaluation. I brought a piece of technology up for him to use. And once I saw that he could spell, that spelling was also intact, I just kind of shifted over a keyboard to him, and I said, well, now you can say whatever you want to say to me. And he gave me a smile, and he typed out this message: when can I get the hell out of here? Okay. So until then, he was seen as a very compliant patient, but in his behavior, he had given up all hope, because all he could do was comply to what was happening to him. All that really needed was time, okay, which isn't part of what most healthcare SNFs are providing in terms of what I do. Okay, here are two other examples. The young woman here was in the hospital for 6 weeks with no means of communication. Her family was getting highly concerned. She was mechanically vented, and she was starting to have what is known as hospital psychosis. Right? The father, who is a very verbal individual, started to complain to the hospital, there has to be something you can do to help my daughter communicate. So the SLP in the hospital called up a vendor or a manufacturer to bring in a device, a $17,000 eye gaze device, wheeled it up to her bed, set it up for spelling, and basically left and said, now you have something that you can use. Okay. Well, within a matter of hours, she was fussing, non-compliant to using that system, and the family pulled it away, and then they started looking through who can we get to help, and they landed again at my clinic. So I went in and did a more comprehensive evaluation to understand where her skill level was at. You can see the system that we set up had minimal locations to what the other system was, but can you see how it is mounted and it's tilted to adjust for her vent and then her ability level? So now she was able to communicate in the hospital situation, and I want to say this woman had a previous disability, but now she's permanently mechanically vented. But she has moved up in her technology. She's at home living, and she's running a nonprofit organization. Right. Our other patient here, you can see what we do when we go into a hospital is put a big sign up indicating how this patient communicates so that nursing and hospital staff is aware that they have a means to communicate. And here are two of my interns that are working with this woman. Now, this woman has a disability. She has a cognitive or intellectual disability also. It is obvious that her language skills and overall cognition is not of a typical adult. So an expectation of her using technology like this would maybe be out of the realm of what most people would be thinking. But again, doing an evaluation, setting it up at a level that was consistent with what she could do, she was relating fine using that system. I went into the hospital during the daytime to look at how the system was being used. Every time I came in, it had been taken off her bedstand and put over on a shelf or closet area of the hospital. And I picked it up and I saw the last message that she had typed in. It was not grammatically correct, but it was, "No nurse, want see doctor." So even that kind of empowerment to that patient was showing how much she was aware of the type of care that she was getting. Right. So here are two other patients that I've seen. This woman right here has aphasia. Well, but did she? She had a stroke, and so she had a severe oral motor speech disorder, but was diagnosed with aphasia because she had had a stroke. Well, her language really was intact after some intervention, but her oral motor speech disorder or dysarthria was not going to go away. And so she could use a high-performance system to relate perfectly what it was that she wanted to say. She had an adult daughter that could know that was working, that couldn't drive her to therapy sessions. So therapy had to take place in the home. And her husband was also ill, so he couldn't drive her to appointments either. But it was such a joy visiting her because she always made brownies the days that we came. So, and then we would sit down and have a conversation and show her something new that she could be using in her device or do some pre-programmed messages that she had indicated. There was a notebook feature in this system, so what she could do is go in and create these notebooks so that when her daughter came to visit after work at the end of the day, she had a list of, this is what you need to do, or grocery shopping list, or this is what I need now. So again, she was able to be in her home, be very independent, and have a much higher quality of life, and be able to share. So, the joy of sitting down at the kitchen table and relating. And what this woman could benefit from was really parishioners coming and visiting her also, because now she could talk. This is another one of our clients at South Hills Village Mall in Pittsburgh. And I'll give that a little plug because we've worked with this particular mall over the years, and we have over a dozen of the stores in this mall that work with us at our camp, and we've gone in and trained their staff of how to relate to clients that cannot talk, or customers of theirs that cannot talk that may be coming in with technology or some type of disability. And this is a young gentleman with autism, and his family really wanted him to be able to go out in the community and not melt down if they were shopping. And so we did a lot of visits to the mall to desensitize him to that, but you can see he's wearing earphones so that the noise in the mall isn't like overstimulating him. We rehearsed things that he could say in the mall to be more independent, and this particular client loves going to Lush, if you are familiar with that store. It's like natural cosmetics and soaps, and he loves the smell of that store. I can tell you we have other children with autism that anything that's olfactory, there's going to be an avoidance. But he's a Lush favorite, and they know him in there now. And so he can carry on little conversations with them, back and forth exchanges about products that he likes. And he loves their shampoos and loves to smell them. So this is just if you download the slides, just some things to consider is what are things that I can do if I'm confronted with somebody that needs an alternative way to communicate and they have a system? What are my do's? And then what are my don'ts? Okay. So I'm going to look a little bit at the don'ts first, is because a lot of times people feel uncomfortable in that silence is disturbing. So when we ask an open-ended question and there's not an immediate response, we have this uncomfort level that we have to ask another question. And frequently it's not repeating our question, but it's asking a completely different question. So using any type of technology is always slower, and a lot of times individuals with disabilities, depending on the type of disability, have a longer processing time to formulate their message, and or a longer time in order to generate that because of fine motor difficulties. So I have several handouts up here if anyone is interested at the end of our talk. And I brought one of the devices that we use, and then a manual communication board that is a nice hospital type of board. And one of the things that I will say is that no one intervention fits everybody. And a lot of organizations just want to say, which one do you want? We'll get that for everyone. And that's especially true with hospitals, because they can do a bid out process, get one piece of technology, and then assume that any patient that needs a means of talk can use it. And it just doesn't work that way. So I'm going to now turn it over to Father Daniel to discuss what's happening at the parish level.
Thank you, Dr. Hill. So Dr. Hill asked me to share with you a little bit of the perspective from parish life and how we meet the needs of these people on a parish level. And I'll just tell you right on the outset that this is very difficult, mainly because we're dealing with usually the difficulty is not the people who cannot speak, but it's the people who can speak, who get upset that people can't speak, and or in our case, we have two young students who have autism who make a lot of noise in our services. And there's some people that are so intolerant of that they will literally report you to the bishop if you're not, complying with their silence as they wish it to be. This happened to me. So I went to my bishop at this meeting and said, do you know who I have in my parish? Do you know who it is that is being noisy, right? And of course, they didn't. And so when I shared that with them, everything changed, of course. But I wanted to share with you some basics on meeting the parish needs. So if you go back one, Katya, first we have this lovely slide of Katya, of course, Dr. Hill, working with Delaney, and this is one of my parishioners, Karen, and you can see that they're working with her on her device so that she can communicate. And it's very important that on the outset that everyone in the parish understands what's going on, because if they don't, they won't know how to relate, and they will, of course, react in a negative way. So first is to educate our people. And what can we do? Increase education and awareness of the needs of the persons without speech in your specific parish. So when I first came to this parish, I actually baptized Delaney when she was an infant, and her autism did not develop until later, 2 or 3 years later. And so we didn't really know, and even the parents didn't know what was going on. You said, why isn't Delaney speaking? Why is she acting differently? What's going on? And so eventually they figured out, they had her tested, and they realized that this was the case. So she's now 4, and she has not communicated verbally as we would expect normal children to with forming of words. It's mainly sounds and things like this that she makes. So we have to ask our question first is, are we educating and making people aware of the problem? And I would say that you could use these ideas, not completely, but some of the ideas. So have your parish priests give special homilies about the importance of these needs. And I've had to actually do that in my homilies because, sometimes you can speak with people individually and they don't get it. But when I spoke directly to it, and I almost had to because as I was delivering my homily, Delaney's running up the middle of the aisle, acting crazy. And so I just touch her on the head and I talk about her. And I relate how she is a part of our parish as well. You have to model this through acceptance, through tolerance, and through patience with these special members. We also use church school as a way to teach this and to explain it also to other children. Right now we're in that stage where Delaney is interacting with other kids. So how do you explain to another 4-year-old that this 4-year-old has special needs, So it's very difficult, but we just kind of go through it and take it one step at a time. And then the other option would be to have someone come to your parish if you were really desperate and said, we need someone to come and explain this. And Katya, I'm sure, would be happy to come to your parish and help you work through some of these issues. So the next slide has a variety of kind of little situations that I wanted to express. So this is Delaney, and you can see her interacting with another young girl who has speech, and her just interacting with her on her device. So you see that the other girl is there, oh, I see your device, so I'm going to communicate as well with you. Here's Timmy, who is sitting with his father, both on their communication devices, obviously, right? We all have communication devices that we use all the time, don't we? So Timmy is here with his father, and this is part of the process. I would say that neither Delaney nor Timmy yet are proficient at using their devices yet. It's very early on. Timmy, although he's 11 or 12, has just begun to start using it. Part of the problems with these communication devices is we're so not used to doing it as those who can speak that we don't have the patience, as Katya said, to really help others learn how to do it. So we're in that process in our parish. We're kind of learning how to do that, how to manage that within the context of our parish. So We also have a Sunday school program that Timmy is interacting here. The Catechesis of the Good Shepherd, if you're familiar with that, is a wonderful learning program for children that it takes them on their level where they're at. And so it's going to adapt very well to us using augmentative alternative communication devices and so forth. So interestingly enough, Timmy and Delaney both do not commune. Delaney communed with Holy Communion when she was little, and Timmy a few times. But part of my struggle as a priest has been getting them to try to commune. And so every Sunday, it is a kind of a process that we go through. And this is how it is with people, especially with young children with autism. They need a lot of repeats. And so we bring them forward to commune. I hold the spoon. I say, would you like to commune today? And I do this over and over. And usually it's a reaction, no, no, and they run away. And so we kind of comically smile at it because we're being persistent and we're continuing to do that. Now, the next step will be to, which Dr. Hill and I are going to work on, is to actually, outside of liturgy, have me come out in my vestments, come down the stairs and repeat this process, even though it might not be Holy Communion, but just repeating this process to try to train them to understand that it's okay. And again, we're at a difficulty. What are they saying? We found out from Timmy's father that he loves the liturgy. He loves the services of the church. He enjoys being there, even though at first he would make noises, right? Kind of anxious noises at times. But now he's really quiet and really complies very well to the liturgy. But it took a lot longer for him at 11 and 12 years old than it would for, say, a young 4 or 5-year-old who quickly, kind of picks up what the signals are and what you're to do and not do. So Timmy is a fascinating case and one that we continue to work with on getting him to communicate and to commune as well. And then I put up this picture of our ladies of our parish, and Anne on the far corner there is just experienced in the last year severe dementia, and she is being placed in a home to care for her. But, all of these ladies in their own ways have difficulty communicating. So part of what we're saying here is for us to be sensitive to those that have those kind of needs and not just avoidance, run from them, which usually people do. Oh, you can't talk, she has dementia, I can't talk to her, so she can't understand me, so we kind of leave the situation. But really the challenge for us as Christians is to really bear one another's cross and burdens together on a parish level. And I think especially when we have these kind of difficulties, we really see it. If anyone desires to follow or to come after me, let him deny himself, take up his cross, and follow me. And I think sometimes on a parish level, we actually have a cross in our parish to bear as a whole. It's not just Delaney's parents or Timmy's parents who have this cross to bear, which they do. But we as a parish also have to embrace this cross and realize that it's our cross as well. In parish life, we understand that we're all made in the image of God, and we've heard this many times. Whether we are a normal functioning person or we have a cross to bear in our lives, the cross that we must bear in parish life is the one given in our particular body. So your own parish life has its own crosses to bear, your own unique individuals and persons with special needs. St. Paul writes and says, I, therefore, the prisoner of the Lord, beseech you to walk worthy of the calling which with you were called, with lowliness and gentleness, with all long-suffering, bearing with one another in love, endeavoring to keep the unity of the Spirit and the bond of peace. And then in his letter to the Thessalonians, he tells them to comfort the faint-hearted, uphold the weak, and be patient with all. And we would say, of course, these are the things that we should be doing in our parish. But it's another thing to actually flesh them out. It's one thing to philosophically and theologically talk about bearing one another's burdens. It's a whole nother ballgame to do it in reality. So members of one another, and I want to emphasize this point because we sometimes forget it. And this, the passage read initially in our opening session was from 1 Corinthians 12, which is a parallel passage to this passage in Romans chapter 12, talking about spiritual gifts and the role of the body. We have many members in one body, but all members do not have the same function. And I would say that Delaney and Timmy have a function in our parish. And that function is to teach us, to remind us of humility, to remind us to get off of our spiritual high horses, because I find many times people come to church with this attitude that, well, I'm here to worship God. I'm here to get my needs met. I'm here to suck from the church and walk away feeling good. But in reality, as our speaker just spoke to us, the reality of suffering, the reality of pain, the reality of difficulty in that liturgy when that screaming voice is going on and you can't focus on the words of the liturgy, is our moment to ask ourselves, where are we? What place have we put ourselves? Are we really individuals of one another, or are we just an individual? And I think these are very important points for us to ponder and think about. Be kindly and affectionate to one another with brotherly love, honoring and giving preference to one another, not lagging in diligence, fervent in spirit, serving the Lord. And this is my mantra for this year for my own parish. Rejoice in hope, be patient in tribulation, continuing steadfastly in prayer, and distributing to the needs of the saints, given to hospitality. Bless those who persecute you. Bless and do not curse. Rejoice with those who rejoice and weep with those who weep. We have to weep with Timmy's family sometimes. We have to weep as we did on Sunday with Judith's daughter Delaney. The situation was Delaney was in the choir loft and wanted a toy that another boy had, and they got into a little tussle like every kid does. And, there was kind of this back and forth and embarrassment and so forth. And Judith was weeping. The mother was weeping in the foyer, in the vestibule. And Katya went and was just giving her a hug and saying, it's okay. She was embarrassed. She thought that her child was worse than any other child, when really her 4-year-old with autism is no different than any of the other 4-year-olds. Okay? So part of our bearing with one another is to do just that, to be there to console and to love and to say, it's okay, and we're members of one another. So don't set your minds on high things, it says, but associate with the humble. How many of us do we run from the humble? We run from those who are lower, who can't speak, or who look funny or act weird. We don't love to be with them. We don't desire to be with them. We don't want to associate with them. Don't be wise in your own opinion. Pastoral care means a lot of things. It means that special care must be given to those individuals and families suffering with these needs. The parish pastor must communicate with the families and the individual if it is possible, which I try to do when I'm able to on learning the communication devices for Timmy and Delaney, that they are accepted and that they are loved and they are part of the body of Christ. And I would say that my meetings privately with both the parents of these two young people have been profound, because when I told Judith initially that, listen, I do not care how loud your daughter is in church. I really don't. I said, if she gets really unruly, just take her outside for a moment, but bring her back in. I reassured her that I am not going to cast judgment, that I'm not going to be angry, that I'm not going to come down on her for all this, because honestly, as Katya would agree, she probably would never come back. We've heard other stories of this where people experience negative things and they say, I'm done with it. And so it must be a priority that we take these special members and treat them specially, just as we do our own body has special members that we treat specially. The pastor must also allow for the use of AAC devices and encourage parish members not to exclude or reject unique members of the parish. Instead, we must assist and train others to participate with the child or individual in all communication efforts. And I think this is where the rubber meets the road, right? The reality is we can talk about it, but now if we're going to put things in place to actually help people to communicate with them, now it's really getting difficult. But this is what we must do. And I would say assist and training is part of what we do. Katya has an office in our hall. She sees patients regularly as a part of the ministry of our church. And this is an opportunity to allow other members to be trained. Some people might have a special desire to say, I'd like to learn more, but we encourage all of our parish members to get involved in some way. Working with specific persons like speech therapists or other assistants should also be encouraged, and holding a special meeting perhaps even to address this issue, which we've done kind of on our parish is not huge, so we haven't had to do that, and I've been using other alternative means to kind of get that message out. But essentially that's at the heart of it, is that the goal is always to keep the unity of the Spirit and the bond of peace, because a lot of times these individuals can become divisive if you allow other members to formulate ideas and thoughts that are not positive and are not in the direction of the body of Christ. So, Katya ends with this lovely quote: "The silence of speechlessness is never golden. We all need to communicate and to connect with each other, not just in one way, but also in as many ways as possible. It's a basic human need, a basic human right, and much more than this, it's a basic human power." And what we're trying to communicate to you today is to not allow these things to slip through the cracks, to think, oh, somebody else will take care of it, or it'll be okay, or it doesn't matter. But actually, the weaker members of our parish, the more humble members of our parish, we should be seeking to associate with and to lift them up and to let them know that they're a part of the body of Christ. So one other example before I close, and one that I wrote in the paper that we put out, which was, you might ask the question, well, are there communication devices in the Holy Scriptures? And in Luke chapter 1, Zacharias, as you recall, was made mute because of his sort of doubt of God, right? And as the story goes, it's really a communication device, because what happens is he comes out and he can't communicate, and the people are like, wow, something's happened to him. He can't talk to us. What is going on? And there's a little bit of frustration. Well, he ends up continuing to serve his time, and eventually it comes to the point where they're asking him, he's going to have a child, John, and they ask him, what are we supposed to name the child? And Elizabeth says something, and he says, no. He's trying to stop them. And it says literally in one translation that they gave him a communication device. They literally gave him a papyrus and paper and something so that he could write it down. And it says literally, if you look right in the scripture, that he wrote down and said, his name will be John, right? So we see even in Holy Scripture that communication devices and our need to communicate is very important. And so I would encourage all of you to research more, to look more, and to see where your needs can be met in your own parish as well. Any other questions, or to have any questions for us? Yes.
So, we had a deaf girl. Oh, I'm sorry.
Yes, please go to the microphone.
Yeah, we in my own parish, we had a young girl who was deaf, and and therefore had speech issues. But I think the thing we were most concerned about was, how do we make the liturgy be alive to her? Because, there's the visual component, but there's a lot of hearing in the liturgy. Ultimately, the family moved across the country to another place, so we never had the chance to work with her beyond maybe a year or two. But I wondered if you have any suggestions for what you can do, not just for communication, but also for kind of communicating the liturgy in cases where there's some sort of impairment. I mean, and we also have some blind, we have one boy who's been blind from a very young age as well, and I think it comes into play there.
It's still part of it. Katya, you want to go ahead.
Well, my first thing would be to understand the deafness and then what type of amplification she might already have. So that's what, So depending on the severity of the deafness and whether or not she can benefit from amplification, and whether or not the parish could use an FM system, right? And then if she's signing is there someone that can be translating the liturgy? So are there people in the parish that want to learn some sign in order to serve as translators? But another thing is just remember Father, Tom Hopko, of talking about how the liturgy just is full of our senses, all of our senses, that we smell, we taste, we hear. And like, where could she stand near the choir to maybe get the vibration of sound? Well, great. Well, you see, so sound vibrations. Yeah. And a similar thing would be for those with visual impairment. What could we do? What could we do in terms of enlarging things that more visual stimuli, or tactile if you're very visual impaired. So I do tactile symbols, and the parish could be marked with some specific places with tactile symbols. If the person's not a Braille reader but could benefit from tactile symbols indicating certain aspects or areas of the church. So I guess that's the answer to that, and then it's really understanding the person's disability. Okay. Other questions? We left room for questions and discussion. Yes.
How is it these days?
Go to Mike.
How is it these days with getting these devices covered by insurance?
That's a wonderful question.
I'm a social worker.
Yes. Well, certainly it depends on the type of insurance that an individual has. If we're talking about pediatric, school systems do have to provide, but then again, that depends on, are they doing a comprehensive evaluation? Or in the state of Pennsylvania, one of my very disappointing things is that schools are just assuming they can give an iPad to anybody, and they've addressed that. And I feel, sorry for Apple, but an iPad is probably one of the least useful substitutes for a speech generating device. And that's the term for that type of technology. In 2001, the Centers for Medicare and Medicaid approved funding for what they termed durable medical equipment, gave codes for speech generating devices. So all major insurance companies fund SGDs, but it has to be through a comprehensive evaluation that is conducted by a speech-language pathologist signing the report. Now, we know that there are some questionable ways that these evaluations are conducted, so I won't get into that. Medicaid and Medicare do cover, but in Medicare, for an expensive device, there might be a significant co-payment. But, for example, if you are diagnosed with ALS and you are on Medicare, or your insurer has a copay, the MDA Association, you can write a grant to then have $2,000 cover that copay for most technology. So it really is a matter of having an informed speech-language pathologist that can do a comprehensive evaluation and explain to the family and or an individual's team the full range of their options. So they're involved in the process. And I think that was, some of the examples of many of my patients in my clinic. We do a lot of, we're the second opinion and the third opinion because people have gotten equipment that hasn't worked. It's just not the correct match. And that will sometimes be a several-year process because it will be the fault of the individual that cannot talk, like their skills are not such that they could benefit from AAC interventions. And for the most part, what we find is that the evaluation was not comprehensive enough and that the full range of options was not shown to them to do a appropriate match.
Thank you.
Mm-hmm. Yes.
Hi, I'm Sandy. I'm an occupational therapist. I work in a psychiatric hospital, and we're seeing an increased amount of patients from DDD in our forensic settings committing violent crimes, and a lot of the underlying issues are communication issues. I see a bunch of nonverbal patients, and we do not have access to speech language pathology, nor is it going to be really feasible in the near future. What do you recommend in terms of good comprehensive evaluation tools that maybe occupational therapists, social workers could do to even discern their comprehension level? Because sometimes we lose information about where they came from, what school systems, how they receive services, and they fall through the cracks.
That is such a powerful question, and I'm just having an emotional reaction to it. My first question back to you is, why isn't there a speech language pathologist as a member of that team if there's individuals with communication disorders? I just don't even understand to be able to begin to answer that question, because it's not within your scope to do that evaluation, scope of practice. So I could suggest tools. You could, do a screening to say that their communication is insufficient to meet their needs, or they have communication is not meeting medical necessity. That's the term that CMS wants us to use. Yeah. But the person that CMS says has to make that call is a speech language pathologist. So can you answer that one to me? Why they're...
I do work for a state hospital, and I think eventually it might come. We have been having a behavioral team, so we're adding, but it's a very slow process and takes a lot of advocacy. And with the state system, if it hasn't ever been done before, then it's likely not to happen for a very long time. So that's the answer. But how do we become effective? Is there any way to become effective with these patients when the system is kind of failing you?
I'd like to kind of answer that now, but I really would like to just talk to you like one-on-one about that, because I think there's a lot of issues involved around that question about what you can do within your scope and what resources you might be able to bring in. So certainly there are some resources up on this table that the AAC Institute provides to get maybe administrators to understand what is possible. But then it's the recognition of there is one of those documents, the right to communication, which is by the National Joint Commission. That every human being has these rights to be able to communicate. You could take this Bill of Communication Rights and look at your patients and go down, can they do this? Have we provided for this? Have we provided for them the right to refuse or reject undesired objects, actions, events, or choices? Right. And so, this is a national committee, so these are things that, how do we then make this happen for these rights?
Yeah, you can talk if you want. Yeah.
We both work in forensics, and I'm even in the more restrictive environments where we don't even have OT. I'm the psychiatric social worker. And a lot of these would be seen as weapons in my setting, and I don't even know that our individuals have those rights that are incarcerated. And I don't know if you know of any advocacy group where we can bridge communication. I don't want to be stirring up trouble, but we get people on the autism spectrum that are incarcerated for long periods of time, who really struggle with communication. The best we have is a little pencil and a piece of paper that we can give them.
No, I can show you some other things, and you're thinking of an apparatus or a device, any kind of device that someone's holding they could weaponize it, right, throw it. Well, there's other things that can be done. Simplified sign even that gives, in simplified sign, for example, very easy to teach. It's not like, American Sign Language, but that's just using body parts. Other types of symbol sets that are manual symbols. So I'd like to just talk one-on-one on that with you so I could give you some examples, along with that reference for the National Joint Committee and the American Speech, Language, and Hearing Association, and of course, my nonprofit, the AAC Institute. We have these action point handouts, and if there was one that I might be able to create that would be specific for you, I'd be happy to do that. But we have several that some of them might be able to be beneficial to you now.
Quick this is, but I work with a lot of patients that it's not that they can't talk, they're non-responsive. So I don't know if you have if you have clients or people that you've worked with that are it's how can we communicate to people who it's not some of them have had a stroke. We've got that situation also, but you know what I mean, people whose illnesses have brought them to a place where they are not going to be able to talk, and it perhaps could be the end of life or not. They may be for an indefinite period of time in a state where they
Are you saying non-responsive in terms of a comatose state or non-vegetative state?
They're not
to know whether or not they're aware of.
Right, their eyes move, but we can't tell. I can't always tell whether they are cognitive or not. But a lot of the residents that are in that situation, whereas you're dealing with people who cannot talk, but we also don't know whether they can understand or I can tell sometimes if they track with their eyes that they can follow me. I do one of the things on the don't do list, which is to talk, but I know they can't talk back. They're not going to be able to talk back to me.
No, they're not going to.
Just if you could.
Again, that's where an evaluation to establish whether or not you can identify some means of a yes or no. Now, I'm going to share something with you because we're on a discussion and there's not a great answer for that. And again, I'd like to just sit down with you and show you how I would do a bedside eval for somebody in that state. But my current research is in brain-computer interface work. Okay, so we've been using EEG wet or gel electrodes to be able to pick up a P300 brainwave from someone being stimulated with a visual stimuli. Okay, so I'm using those systems to research communication using brain-computer interface as an access method. But there are some research labs that are using BCI to see whether individuals that are in a non-responsive or vegetative state can actually use a BCI, or a BCI could be used to train them to see if they are aware of their environment. So when I was at the meeting in May, the International BCI meeting, it was a little bit unnerving for me to see that, yes, indeed, they were finding a certain percentage of patients that were not supposed to be aware of their environment, that they were able to use a BCI to indicate that they were aware of what was being said. So I think that in a sense that's something in the future for you, but to be aware we can never give up on of what spirit might be alive in somebody that we have to be ministering to, and being aware that we can be bringing Christ to them, or Christ could be lying in that bed for us, and that it's not just routine care that we're providing, but it's addressing a spiritual need for them, but also a spiritual need for us. Yes.
Father, this question is for you. You mentioned you set goals for education and awareness. To me, that implies some method of tracking progress against those goals. So how do you, and if so, how do you provide a structure around that in terms of evaluating how well you're doing in terms of awareness and education in the parish?
Good question. Honestly, I would say that if it wasn't for Dr. Hill, I probably wouldn't be doing this. God gifted me. I can't claim to know anything about it, but she came to us and saw our needs and helped us. And so I'm learning as I'm going. And I think we're actually learning together as we're going, even about the goals, because on parish level, who really deals with this? Who really talks about it? Usually it's the parents and the child, and the priest is like, okay, God bless you, have a good day. And, we don't have these kind of interactions. These students are coming weekly to our parish hall to meet with Katya to basically train them, to teach them how to speak. So some of our goals, our immediate first goal is to be able to have, on a parish level now, is to be able to have these two young people communing. Our goal is to have them commune. Because communion is communication. Communion is connection. So that's our real goal, and we've been actually just looking to that. So the benchmarks that we've looked at are just simply, as I said, they're very slow. So it's not like, oh, this week we're going to do this, and next week we're going to do this, and then this week we're going to do this. More like, this year we're going to try this. And I would say for the last year, all we've been doing is just bringing them up in the line to communion with their parents, having them go through the process of attempting communion. The next step in the goal will be to intensify that a little bit more and bring that kind of up a little bit higher. So I would say that for every parish and every individual situation, we can't really, that's why I didn't put all the goals, because they're going to vary depending on your situation, who you have in your parish, who the children are, what they have. We have 2 students with autism, but we also have another individual with ALS. Now, right now, she can communicate fine, but her communication is slowly going down, as you know this disease does. So now we're at another level. When I go to visit them, how do I communicate? How do I understand this? So part of our goals are we're basically just taking it one day at a time. Our goal is for communion. And really, it's about the scriptures, about being members of one another. So the goal is to be a member of them and let them be a member of us. So part of it is just listening to the parents. Part is just encouraging the parents, encouraging those around as we set, kind of goals as we're moving along. So we say, oh, we accomplished that. Now we're going to look and say, well, what's our next goal? Because we don't really know until we find out. That's why I think a lot of this is really up in the air. It's like juggling, because you don't really know what's going to happen next. And sometimes a parent could fall out, someone could drop the ball, and now you're starting over again. So I think if you're talking about a specific, your own parish or whatever it might be, I would say that you just have to sit down and evaluate it on a case-by-case basis, depending on what the situation is, and then set your goals based on that. So that's kind of how we're doing it. We're kind of winging it in a way, but we have an expert, so it's helping us.
Thank you.
Well, I'm going to add a couple of goals that Father forgot. Both of those children were not going to Sunday school. Their parents were not taking them. And so now with this new program in the atrium classroom, you saw pictures of them there because that's a very sensory room. They're going in there, and they're not going in there with me. They're going in there with the teacher or someone else that's in the education program. So I think that's a huge huge goal.
And I think one of the other things that we have in our particular case that I just wanted to mention is that because we have these parents, as we talked about Judith breaking down when her kid was having a problem, and we've been just talking about this. One of our goals is to have personal assistance for these particular students, especially these kids, so that their parents can be a little bit relieved. Some of the tension and the angst that happens is just the embarrassment from a family over their child. And that can wreck them spiritually. It debilitates them when they come to church. They stand in the back. They're in a humbled position, and it's very difficult for them. So part of it, that's one of our goals, is to also help incorporate individual assistance to help people with those special needs. And that could be ALS, it could be autism, it could be anything. Even, I would argue, even, which people do it naturally, even dementia and Alzheimer's, people that are coming to church, and it's usually a family member that's assisting them, but maybe as a whole body we need to assist them, helping them up and helping them move and communicating with them. So just another thought, but good question.
You know, I think we're supposed to end at 5:30, at 5:15, so that we can attend Vespers at 5:30. So I think we should thank all of our speakers. They're fabulous.